The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/CAV860. Downloadable infographics and additional resources are also available.
Hello, I'm Jason Luke, an associate professor and director of the Cancer Immunotherapeutic Center at the University of Pittsburgh and UPMC Hillman Cancer Center in Pittsburgh, Pennsylvania. I'll be presenting this Peer View in Motion, expanding the benefits of immuno-oncology to more patients with solid tumors through novel rational targets and combinations. This is a visual exploration of promising approaches on the horizon. And we'll begin on a high level discussing immuno-oncology, really as a modern revolution in cancer treatment. So historically, we're all aware that surgery and radiation, as well as chemotherapy eventually, were the standard approaches that we employed in our attempts to cure and palliate patients with cancer. However, the past decade, it's become increasingly clear that immuno-oncology agents are likely to become the backbone therapy in our attempts to cure more patients with advanced cancer. And that improvement with immunotherapy has really been predicated on the broad activity of immune checkpoint blocking approaches. Here you see the interaction between an antigen-presenting cell and a T cell to facilitate T cell activation. And canonically, this two-step process includes presentation of antigens through the major histocompatibility complex by the antigen-presenting cell to the T cell receptor. However, that interaction is not enough and requires a secondary co-stimulatory interaction between B7 ligands and CD28. And if both of those interactions take place, a T cell can become activated to look for its antigen and attempt to clear it. After activation, the T cell traffics CTLA4 from the endoplasmic reticulum to the plasma membrane, where it has a higher binding affinity for B7 ligands and therefore shuts down this interaction. And for this reason, some people have described checkpoint blockade as taking the brakes off, so to say. And with this understanding, there became an urgency to develop therapeutic agents to interrupt this, and ipilimumab, or anti-CTLA4, was the first checkpoint inhibitor to come into clinical practice in melanoma. More broadly, however, immune checkpoint blockade has been rushed forward in the clinic owing to the substantial clinical benefit towards blocking the PD-1 or PD-L1 interaction. And we're aware now that another mechanism that limits anti-tumor activity is this interaction in the tumor microenvironment, where some patients mount a spontaneous immune response in which tumor-infiltrating lymphocytes come in contact with the tumor, but the tumor can observe their presence via their secretion of certain cytokines and chemokines, particularly interferon gamma. And in response to interferon gamma, tumor cells upregulate PD-L1, which then can block the incoming TILs by that interaction with PD-1. And then for that reason, blocking that interaction has been a priority and obviously successful in clinical practice. Now, the current landscape and role of immunotherapies is an ever-emerging topic where we have 3 approved PD-1 antibodies currently with nivolumab, pembrolizumab, and cemiplimab, 3 PD-L1 antibodies currently approved with atezolizumab, avelumab, and durvalumab, and 1 CTLA4 antibody with ipilimumab. Now realize there are many more agents in these both classes that are coming forward for registration in the near term, and the length of the list of these emerging agents really goes off the page. But it's enough to understand that these are now available for use in selected immuno-oncology monotherapy indications, with many different tumors having a role for checkpoint blockade in the treatment armamentarium. And similarly, combination immunotherapies are rushing forward to replace monotherapy in many different indications. Those can include PD-1 plus CTLA4, and with other treatments like VEGF inhibitor, chemotherapy, and all of the above. And so to highlight that, we can see now that combination immunotherapy is standard in multiple tumor types. And as examples, in melanoma, PD-1 plus CTLA4 is considered an equivalent standard to PD-1 monotherapy with nivolumab. However, for high-risk patients, most in the field believe that a PD-1 and CTLA4 combination is more likely to benefit. Combinations of PD-L1 with targeted therapy in melanoma are now approved, with a BRAF and MEK and PD-L1 inhibitor combination. In renal cell carcinoma, again, PD-1 plus CTLA-4 immunotherapy is a standard of care, particularly for high-risk patients. And the combination of a PD-1 or PD-L1 antibody with VEGFR2 TKI is also an approved standard of care. And finally, as an example, in non-small cell lung cancer, the role of immunotherapy has been increasing dramatically with monotherapy use of a PD-1 or PD-L1 antibody in high PD-L1 expressing tumors, and in the rest for metastatic disease, combining PD-1 antibody with chemotherapy, and PD-1 plus CTLA-4 immunotherapy further as a consolidative or curative approach. Following chemoradiotherapy, the use of anti-PD-L1 has substantially improved progression-free and overall survival. Now, there are limitations on current immuno-oncology combinations, which is that unfortunately, despite more aggressive regimens, only a proportion of patients still benefit. And toxicity is a consideration, especially with combination approaches. And multiple different approaches are being explored to try to reduce toxicity. Some of these include changing the dosing strategy, such as the putative flipped dosing of ipilimumab from the standard 3 milligrams per kilogram to 1 milligram per kilogram in combination with nivolumab in many disease settings, as well as engineering CTLA-4 approaches such as Probody or other sorts of considerations to try to reduce systemic toxicity. So when we think, though, in the metastatic setting about developing novel cancer immunotherapy approaches, we can bucket them into various different categories using our understanding of the tumor microenvironment. So an initial approach might be to stratify tumors by their immune status before patients are selected for early phase clinical trials. And we can use that via what's called the immunoscore or the T-cell inflamed phenotype. And you may have heard this in lay press sort of as hot and cold tumors. Another nomenclature that's been pursued are immune excluded versus immunosuppressed tumors. And various different mechanisms, therefore, might be put into different buckets that might be harnessed to treat patients whose tumors manifest these different phenotypes. And there is so many, in fact, that it's hard to go over all of them. And we'll spend the rest of the presentation talking through why each of these might make sense. So drug development in immuno-oncology can fall into multiple categories, but I've taken the approach of trying to bucket them into a few different that I think can organize them well. And so the first would be next generation immune checkpoints, and particularly I'd like to talk about LAG-3, TIGIT, and TIM-3. And then as a next step, I'd like to talk about bispecific approaches, and these can fall into multiple categories, including CD3 redirection, bispecific immune checkpoints, as well as tumor microenvironmental agonists. From there, we'll move on to talk about innate immune modifiers, and generally these could include oncolytic viruses or danger pathway sensing molecules, such as STING and toll-like receptors. We'll move on then to talk about immunometabolism approaches, particularly focusing on adenosine signaling, as well as the IDO or aryl hydrocarbon receptor pathway. And finally, we'll talk about novel targets and immuno-engineering approaches, and really sort of think about where is the field going to go into the next several years. So with that, we'll start by talking about next-generation immune checkpoints, and specifically LAG-3 as one of the more advanced molecules. So when we think about T-cell checkpoints, it's worth pointing out that we can categorize them broadly into two camps. One that include inhibitory receptors, and the other being activating receptors. And so the most success to date in clinical development has been with inhibitory receptors, and we talked about them earlier with CTLA-4 and PD-1 antibodies being part of our treatment armamentarium already. We're going to mention a few more inhibitory receptors, such as LAG-3, TIM-3, and TIGIT, but we'll also note the other side of the coin, which are the activating receptors, such as OX40, GITR, and CD137 or 41BB. Less success has been had in developing molecules against those receptors to date. However, they are and continue to be of substantial interest. When we move on, however, to talk about LAG-3, we can point out that LAG-3 is a receptor that's expressed on T cells as they progressively become dysfunctional. So, sort of in the old days, we used to refer to these as exhausted T cells. However, that nomenclature has fallen somewhat out of favor. But rather, as T cells become increasingly exposed over time to an antigen which they cannot clear, they begin to gradually turn themselves off so as to not to engender autoimmunity in the resident tissue. So we're all aware about expression of PD-1 as a putative exhaustion marker, but LAG-3 is another receptor that can be expressed both in parallel and in sequence with PD-1. LAG-3 is a complicated molecule that has multiple binding partners or ligands, with one of them highlighted here as FGL1. And blocking LAG-3 has shown preliminary evidence of potential utility as a cancer therapy. And what you can see is that in a cohort of patients with metastatic melanoma who had progressed on nivolumab, those patients had their tumors stained for LAG-3. You can see those who retained expression of LAG-3 despite progression on a prior PD-1 antibody. And in that population, if you treat with a PD-1 and anti-LAG-3 antibody, you can engender treatment responses with almost half of the patients having tumor reduction. And this has led to a phase 3 study of the anti-LAG-3 antibody relatlimab. The study is known as CA224047, a randomized phase 2-3 study of relatlimab with nivolumab as compared with nivolumab alone. And in the study, about 700 patients greater than the age of 12 with no prior treatment for unresectable stage 3 or metastatic melanoma will undergo a randomization. Patients with active brain metastases or leptomeningeal disease, as well as uveal melanoma, are excluded. And the trial has a gated approach with a primary endpoint initially for phase 2 to show efficacy in terms of overall response rate, which will then lead to a phase 3 efficacy readout of progression-free survival. And certainly other endpoints are of relevance as well, including overall survival, duration response, disease control rate, and safety and tolerability. Now, beyond LAG-3, there are other molecules in terms of next-generation checkpoints, and one of the hottest in the field beyond LAG-3 is TIGIT. And so TIGIT is another receptor, but this molecule is more broadly expressed across immune cells. And here you can see 4 different compartments of the immune system and 4 different roles that TIGIT can play in modulating anti-tumor immunity. Note that TIGIT can inhibit NK cell-mediated tumor killing, but it can also have direct effects on dendritic cells and suppressing antigen presentation. TIGIT can also impact on CD8 T cells, suppressing their ability to kill cancer cells, as well as impacting on the ability to prime CD8 T cells in anticipation of tumor kill. The most interesting data for TIGIT so far from the clinic is that generated from the Cityscape study, which randomized patients with frontline non-small cell lung cancer but high PD-L1 expression to receive either the combination of tiragolumab and atezolizumab, or anti-TIGIT and anti-PD-L1, as compared to patients who received anti-PD-L1 and a placebo. And as you can see, there was a substantial and statistically significant difference in progression-free survival for these patients who received the combination of anti-PD-1 and anti-TIGIT. A third immune checkpoint that's an inhibitory receptor that you should also be cognizant of is TIM-3. And TIM-3, again, is a receptor that can be expressed on multiple immune cell types. You can see it can be expressed on T cells, myeloid cells, and NK cells to modulate the response in the tumor microenvironment to various signals. TIM-3 also has multiple binding partners. One of the important ones that you see there is galectin-9, but another is phosphatidylserine. And the reason I say that is phosphatidylserine is a danger signal that can be released from cells as they die. And so tumor cells obviously are proliferating but also dying. And this is the kind of molecule that can then be sensed by TIM-3 and other molecules as a danger signal to activate the immune system. Another molecule that TIM-3 can sense is HMGB1, and you can see that on dendritic cells, again with the idea that these cells as scavengers may recognize that cancer is present and activate the immune system, partly mediated through TIM-3. Now, in clinical trials, what's been observed to date is that the most activity for anti-TIM-3 antibodies, again, has been in the setting of PD-L1 positive tumors. And so what you can see in this waterfall plot of patients with non-small cell lung cancer who had progressed on a PD-1 antibody, but who still retained PD-L1 positive TPS greater than 1%, was that the combination of a PD-1 antibody, here TSR-042, with a TIM-3 antibody, TSR-022, could engender treatment response in this PD-1 refractory patient population. And moreover, in some patients, we have seen monotherapy activity for anti-TIM-3 antibodies. So from there, we'll move on past next-generation immune checkpoints alone to talk about bispecific approaches. And in the context of our prior conversation about novel immune checkpoints, it's interesting to think about how we might start to combine multiple immune checkpoints into a single molecule. And so here we show a schematic of a modified antibody that could have the potential to bind to multiple immune checkpoints. So you can see on this molecule the standard FAB-FC on one half of the molecule, but a modification on the other. And so in this sort of a configuration, the FAB can bind as standard to a molecule, for example, such as PD-1, but the other side of the molecule has been modified by changing out the FAB to a single chain variable fragment, which has more flexibility to move around. And with that molecule, then you might be able to bind another immune checkpoint, perhaps even on other cells. A molecule that I've been involved in and interested in is this DART molecule shown, known as MGD013, which is a bispecific PD-1 by LAG-3 binding molecule. And you can see the rationale then is that dysfunctional T cells in the tumor microenvironment might be expressing both PD-1 and LAG-3, and through this dual targeting approach, we might be able to reactivate those T cells more powerfully than anti-PD-1 alone, perhaps to engender treatment response. And in data that we presented at the virtual ASCO 2020 meeting, we combined this molecule MGD013, the bispecific PD-1 by LAG-3 DART, with an FC-engineered anti-HER2 molecule known as margetuximab. And in a population of patients who were predominantly HER2 refractory and expressed low levels of PD-L1 and LAG-3, we saw a robust response rate at more than 40%, with those responses being durable out over an extended period of time. Now, those are bispecific checkpoint molecules, but what about thinking about bispecific tumor microenvironmental engaging molecules? So, various different approaches in this realm have been presented to date. One is this molecule, PRS-343, which is a bispecific molecule which on one end binds to HER2, sort of like an anchor, and on the other end has been engineered to express 4-1BB, CD137, and that's a receptor that helps to activate T cells. And so the rationale here then is that the HER2 targeting will anchor this molecule into the tumor microenvironment, where it can provide co-stimulatory effects to T cells that may come into the tumor microenvironment. And then the treatment is combined with a PD-1 or PD-L1 antibody, in this case, atezolizumab. A similar but slightly modified approach was this molecule, which combines targeting of fibronectin-associated protein, or FAP, which is a molecule commonly expressed in the tumor microenvironment of most cancers, with the trimeric 4-1BB ligand, which is the other side of that 4-1BB interaction. And again, the idea here being binding to FAP in the tumor microenvironment with a more flexible arm on the other side of this bispecific molecule that allows the 4-1BB ligand then to move around in the tumor microenvironment, potentially to agonize T cells, both in trans and in a cis activation sort of an approach. In addition, there are modifications being made to standard antibody formats to use them both in a therapeutic but also a targeting approach. And so here you can see a PD-L1 antibody, which it binds to PD-L1 as standard, but has been modified to have the IL-15 cytokine fused to the Fc portion of the molecule. So the rationale for this approach then would be to give PD-L1, but in addition bring forward IL-15 into the tumor microenvironment to superactivate any T cells that come in contact with the molecule. The most success to date of any of these bispecific approaches may have been with this molecule known as tebentafusp, which is an ImmTAC molecule that combines a targeting domain, which is an affinity-engineered T cell receptor that has picomolar affinity in binding to the molecule GP100. And you'll remember that GP100 is a cancer testis antigen that's been known for a long time, and many vaccines have been developed against that. So tebentafusp combines that targeting domain of a T cell receptor with an alternative domain or effector domain, which is a single chain variable fragment against CD3. And again, you're aware that CD3 is the canonical marker on T cells. And so this molecule physically pulls T cells into the tumor, or really anywhere that GP100 is expressed. By bringing the T cells directly in contact with the tumor, we might be able to engender treatment response. Now, this kind of a treatment is a little complicated in that due to T cell receptor targeting, it is HLA restricted. And so this will set up a new era of biomarkers, which will be to understand the germline of our patients who are going to receive cancer immunotherapy to know which cellular or modified T cell products might be relevant specifically to their immune system. But using this kind of a molecule in a disease setting known as uveal melanoma, or the rare subset of melanomas that arise in the eye and generally speaking are not responsive to immune checkpoint blockade, we can see that patients who have response have the kind of induction of immune effects that we expect. And so in the partial responders, or PRs, you can see all of the orange gene expression, which is the induction of all of those molecules associated with antigen processing, T cell function, and cytotoxicity. And on a multispectral imaging approach, you can see at baseline that these uveal melanoma tumors tend to be quite non-T cell inflamed, or cold, as sometimes referred. And after treatment, we see a marked induction of T cell associated factors with PD-L1 and CD8 infiltration. Many molecules like this that combine targeting and effector domains are being developed. And one recently presented is this molecule AMG 160, which combines the anti-CD3 with an anti-PSMA. And so obviously this molecule could be particularly interested in prostate cancer, where PSMA expression is essentially present in all of the tumors. We'll move on then from next-gen immune checkpoints and bispecific approaches to talk about innate immune modifiers. So we'll start in this realm by reviewing oncolytic viruses as perhaps a next-generation approach for the treatment of cancer with cancer immunotherapy. And you're aware that one oncolytic virus for cancer has already been approved, that being telamogene laherparepvec, or TVEC. So in refractory melanoma, TVEC can be given to cutaneous lesions with the hope of controlling them over time. And a registration intent clinical trial known as MasterKey 265 is investigating the combination of TVEC with pembrolizumab as compared to pembrolizumab and a placebo. And the rationale here again is that the injection of TVEC into the tumor microenvironment may spur the induction of T cells, which can be harnessed with anti-PD-1. And early translational data from the phase 2 portion of this trial confirmed that mechanism. You can see that in patients who have treatment response at baseline, they have modest but present T cell infiltration, as witnessed by the pink dots. But after injection of TVEC into the tumor, we get a huge influx of T cells, and that's only further enhanced with the use of anti-PD-1. So it'll be interesting to see whether this trial can read out to show an improvement over PD-1 alone, and perhaps bring oncolytic viruses more into the mainstream use in melanoma and eventually other tumor types. But oncolytic viruses take advantage of the innate danger sensing pathways within our immune systems. And so these danger sensing pathways predominantly sense foreign nucleic acids that should not be present in our bodies as an infection. And many of these have become targets for cancer immunotherapy, and I'll highlight a few of them, being STING, or the cGAS-STING pathway, RIG-I, toll-like receptors, as well as the AIM2 inflammasome. So when we think through these, the rationale for targeting these, again, is to try to harness our body's ability to sense danger signals and infections, and instead use that to try to activate the immune system against cancer. And so the example of the cGAS-STING pathway is shown here, where tumor-derived DNA can be sensed through cGAS, and particularly in CD11 dendritic cells, to activate STING and lead to signaling through TBK1 and IRF3, and lead to the elaboration of interferon beta, or type 1 interferons. And those type 1 interferons then can attract cytotoxic T lymphocytes and lead to the elaboration of interferon gamma, and turn cold tumors hot putatively, or generate a T cell inflamed tumor microenvironment. A similar rationale exists for toll-like receptors, and particularly toll-like receptor 9 has been of substantial interest and is now in registration intent clinical trials as a therapeutic target. So similar to what I just showed you, dendritic cells, predominantly plasmacytoid dendritic cells, have expression of toll-like receptor 9, which can be agonized by certain molecules, such as in this case tilcitolimod or CMP001. And each one of these molecules then can turn on these plasmacytoid dendritic cells, which can go to the lymph node and prime T cells to come back to the tumor and hopefully eradicate the tumor. And you can see that in treatment refractory melanoma, we can inject these molecules into the tumor microenvironment, where you can see that the injected tumor can shrink, but so can distant injected tumors. And we think that this is really going to be of a substantial interest in trying to reactivate the immune system in patients who develop resistance to anti-PD-1 and PD-L1, as well as anti-CTLA-4 therapies. This has been seen both with tilcitolimod, which is now in a phase 3 study with ipilimumab in PD-1 refractory melanoma. It's also been seen with CMP001, which is now in a phase 3 study in the frontline setting in combination with pembrolizumab in melanoma. Another approach to try to enhance cancer immunotherapy has been to try to harness cytokines to improve the activity of T cells in the tumor microenvironment. So high-dose interleukin-2 has been around for many years as a treatment approach, and we're trying to reimagine how to use the IL-2 axis to improve immunotherapy while not engendering the substantial toxicities that have been well known for high-dose IL-2. But IL-2 stimulates T cell proliferation and induces the generation of cytotoxic T lymphocytes, as well as facilitates the maintenance of NK cells. IL-2 also, though, is involved in the maintenance of T regulatory cells and the elimination of self-reactive T cells. On this schematic, you can see the role of the IL-2 receptor and its interactions both with IL-2, but also the importance of IL-15 as another aspect of this sequencing cascade. So IL-15 is a related molecule to IL-2, which is also being explored in cancer immunotherapy. And several next-generation IL-2 approaches are being harnessed for cancer immunotherapy, with the most advanced being this molecule, bempeg-aldoslucine, or sometimes known as Bempeg, or Nectar-214. And the idea here is that this molecule is not quite the same as the standard IL-2, but rather is a CD122 biased agonist. And what does that mean? It means this molecule tries to go after the beta-gamma subunits of the IL-2 receptor while leaving alone the alpha receptor as much as possible. And the rationale for that is the alpha receptor is thought to be more associated with the Treg or immunosuppressive aspects of IL-2. So this CD122 biased molecule has been heavily pegylated so that after infusion, the pegylations slowly fall off, releasing this CD122 agonist into circulation, where the hope is that it can agonize T cells and enhance the activity of anti-PD-1. In clinical trials, Bempeg has been shown to convert low PD-L1 tumors to high PD-L1 tumors and to engender the influx of the tumor microenvironment by tumor-infiltrating lymphocytes and enhance checkpoint inhibitor response. And so data to support that are shown here from this clinical trial of patients with frontline melanoma in the PIVOT-02 study, in which 38 patients were treated with the combination of nivolumab and Bempeg, and an overall response rate was observed at 53%. But importantly, you can observe from the waterfall plot that several patients with baseline PD-L1 low tumors or negative were observed to have complete responses in this clinical trial. And that would not be what we would expect from a PD-1 monotherapy, suggesting that Bempeg may in fact be able to overcome some mechanisms of resistance and generate a T-cell inflamed tumor microenvironment that can be enhanced for treatment effect for anti-PD-1. In the clinical trial, almost 3/4 of patients at 74% had disease control, meaning complete response, partial response, or stable disease, with early responses seen at 2 months and median time to complete response at 7.9 months. The median duration of follow-up for the trial is 18.6 months so far, and 85% of patients have had ongoing treatment responses. Amongst the patients with known PD-L1 status, the overall response rate in PD-L1 negative patients was 5 out of 13 at 39%, and in PD-L1 positive patients was 14 out of 22 at 64%. And this trial is very exciting and is ongoing in a registration phase 3 trial in the frontline setting for melanoma, in which patients are being randomized to receive bempeg and nivolumab as compared to nivolumab alone. This combination is also being explored as an adjuvant therapy approach for treatment after definitive surgery in stage 3 melanoma. Now, this combination of bempeg plus nivolumab is of substantial interest even beyond just melanoma. We talked about the PIVOT-01 study, which is the phase 3 study for metastatic melanoma. But the PIVOT-09 study is investigating bempeg plus nivolumab compared to investigators' choice of sunitinib or cabozantinib in previously untreated advanced renal cell carcinoma. In the PIVOT-10 study, there's a neoadjuvant and adjuvant treatment of nivolumab with bempeg versus nivolumab alone or standard of care in muscle-invasive bladder cancer who are ineligible for cisplatin. In addition, in another phase 2 study of bempeg plus nivolumab in cisplatin-ineligible patients with urothelial cancer, the combination is being investigated. Another cytokine beyond IL-2 that should be on your radar as a next-generation immunotherapy approach is interleukin-12. So IL-12 has pleiotropic effects on multiple immune cell types, but all leading to the elaboration of type 2 or gamma interferon, which we have discussed at length, can turn the tumor microenvironment into a scenario where anti-PD-1 can be effective. And a company is bringing forward an approach of trying to harness IL-12, which includes direct intratumoral injection of plasmid DNA encoding IL-12, known as tavokinogene telisplazmid, and that is followed by a slight electrical pulse via electroporation. So the plasmid DNA is injected, the tumor is electroporated, and early results show a substantial treatment success in treatment refractory melanoma. And you can see here a waterfall plot looking at the injected and electroporated lesions, showing that more than 40% of them have complete response after this approach. And on a multispectral level, you can see those patients who have this phenomenon have substantial induction of multiple cell types into the tumor microenvironment associated with this treatment response. And clinical trials with registration intent of this electroporation approach of IL-12 are in development. From those innate immune modifiers, we'll move on to briefly touch on immunometabolism molecules. And the most advanced molecules in this space really center on adenosine signaling. And so adenosine signaling is somewhat complicated, but has multiple potential drug targets in this pathway. And so ATP can be broken down in the extracellular space by the molecule CD39 into AMP, and that can then be converted by the molecule CD73 to free adenosine. And adenosine is not supposed to be in any significant quantity freely floating around in your body. That's generally speaking considered a major danger signal for human physiology. And that can be directly immunosuppressive on multiple cell types, perhaps most importantly being T cells. And so the adenosine receptor family is broadly expressed throughout multiple tissues, but particularly adenosine 2A receptor on T cells can sense the presence of adenosine and really downregulate the activity of T cells. And drugs targeting A2AR, as well as CD73 and CD39, are rushing forward in clinical development, being observed to have both monotherapy and combination activity with other molecules such as anti-PD-1. Finally, in immunometabolism space, we'll touch on here the pathway known as the indoleamine dioxygenase pathway, or perhaps better understood as the kynurenine or aryl hydrocarbon receptor pathway. And many of you are probably aware of IDO, as one of the highest profile failures in immuno-oncology was the phase 3 clinical trial in melanoma of pembrolizumab with epacadostat. Now, it's important to understand that IDO is an upstream aspect of this pathway, leading to the activation of kynurenine and downstream activity of the aryl hydrocarbon receptor. So those previous generation of trials perhaps targeted the wrong aspect of this pathway and perhaps used molecules with epacadostat that were not as potent as some others in the field. So there are multiple shots on goal still in this pathway, with multiple companies developing next generation IDO inhibitors, as well as kynureninases and inhibitors of the aryl hydrocarbon receptor. So keep your eyes out, because more to come probably around immunometabolism, particularly in the aryl hydrocarbon receptor. Finally, we'll touch on novel targets and next-generation immunoengineering approaches. So in this space, I'll highlight dual signaling proteins as a potential next-generation step. These molecules take the tact, sort of like bispecific antibodies, of incorporating the ability to agonize or inhibit two different aspects of the immune system at the same time. And so here we see a dual signaling protein that has an activity directly on the cancer cell, but also has an activity on the immune cell. So in this example, one side of this is blocking CD47, or the don't eat me signal, on immune cells, and the other side is providing co-stimulation via trimeric 4-1BB ligand. And we discussed that earlier as a major co-stimulatory molecule for immune cells. So the idea here then would be able to block a cancer-specific process while augmenting multiple tumor microenvironmental cell types. An area of emerging understanding and activity in drug development is that surrounding the glycoproteome. Looking at the glycolysis patterns of the tumor is an area that we're only beginning to understand, but multiple different companies are bringing forward the ability to edit aberrantly expressed Siglix or other glycoproteins on the surface of tumors, with the intent that this may make them more amenable to treatment with the immunotherapy. And so here I show an example that includes a bispecific molecule that has a targeting arm, perhaps a molecule targeting such as HER2 or other, and on the other side is connected to a human sialidase, again with the intent of cleaving Siglec patterns that might make the tumor more available for treatment with immunotherapy. And finally, there are other subsets of the immune system that are being harnessed for cancer immunotherapy. And one of the coolest next generation approaches that I've been seeing recently is this molecule RTX-240. And this molecule takes advantage of the red blood cell maturation process, such that naive red blood cells can be lentivirally transfected to express immunostimulatory molecules. And here you can see 4-1BB ligand and IL-15 as the molecules. After transfection, these red blood cells are then maturated, and after they expel their nucleus, they then float around, both being able to, provide oxygen, but also able to provide very powerful co-stimulatory signals to anti-tumor cells, such as T cells and NK cells. So more to come with this kind of immunoengineering approach, but I think the sky is the limit as we think about being able to harness different cell types for cancer immunotherapy. So with that, I will wrap up and conclude, noting that combination immunotherapy really is the future of cancer therapy. And the T-cell inflamed tumor microenvironment is a biological guide to immuno-oncology drug development, meaning that for non-T-cell inflamed tumors, we may need to do something in the tumor microenvironment to generate that T-cell inflammation that we know we can harness and target therapeutically with drugs we already have, such as anti-PD-1. And many novel immuno-oncology approaches are being developed, including but not limited to next-generation immune checkpoints and bispecifics, innate immune modifiers, cytokines, and immunometabolism molecules, as well as novel targets and immunoengineering approaches. And certainly it is an exciting time in cancer drug development, and keep your eyes peeled for what we hope will be a whole group of new therapies that can advance the field and improve the care that we deliver to our patients. This ends our infographic educational activity focused on new, promising immuno-oncology approaches. I hope you have found the material presented here informative and useful. Thank you very much for participating.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/CAV860. This activity is supported through an educational grant from Bristol Myers Squibb. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.